Hi friends, welcome back once again. In this session, we will be discussing about computer tomography, safety in CT. When we look worldwide, the CT scan has been significantly increased, and increase in number of pediatric CT scans increases in multiple CT exposure of the same patient, because one patient, if it is get admitted, you will do a CT if any abdominal issue, and you will do a check CT later. So the CT scan, repeated CT scan have significantly increased, and increase in number of unjustifiable CT scans too. So computer tomography is widely used imaging modality to establish medical diagnosis and perform image guided interventional procedures too. So more recently, the concerns has been raised about the risk of cancer from medical radiation with a focus on CT scan. When you focus on the modern researchers and paper cuttings, you can see a lot of articles which is coming out about the radiation risk of diagnostic imaging, specifically focusing on CT. Here you can see an article which is about radiation exposure from pediatric CT scan and subsequent cancer risks in Netherlands. Similarly, a lot of paper cuts and a lot of researches which is happening, specifically focusing on diagnostic imaging modalities. So the comparing with the other imaging modalities, the CT scanner have the highest radiation output. Same way, you can see the paper cuttings here. Unnecessary CT scan exposing patient to excessive radiation, also radiation exposure from CT scan in childhood and subsequent risk of leukemia and brain tumor, a retrospective cohort study, a varieties of studies which is being happened during this recent years about the radiation risk which is involved in CT scans. You can simply look into this two pie charts, which is explaining, which is simply giving you the information about the percentage of diagnostic imaging studies. Around 5% of nuclear medicine investigation and 74% radiography examinations, interventional radiology just 4% and CT is just 17%. But on the other hand, you can see the percentage of radiation exposure. You can see nearly 50% it is coming out from the CT scan, and it is 14, 26 and 11 respectively interventional radiology, nuclear medicine and radiography. That is the difference that you can see, the investigation which is happening and the radiation which is coming out. So these are the factors affecting the radiation dose in CT investigation. So we will be discussing one by one direct factors and indirect factors. So direct factors involved exposure technique, X-ray beam collimation, pitch, patient centering, number of detectors, overranging, etc. And indirect factors, which is reconstruction filters. So we'll come to the exposure technique factors. First one is KVP. What is KVP? Tube potential. The tube potential is the voltage applied across the X-ray tube between the cathode and anode. So it is measured in kilovoltage. What the tube voltage controls? What it controls? The energy, the penetrating power of the X-ray photon, the quality of the X-ray beam, and the ability of X-ray to pass through the body tissue. So these three things will be controlled by the KVP, tube potential. And what is tube current? The tube current is the flow of electron from cathode to anode per second in the X-ray tube. It is measured in milliampere, MA. What it controls? What is MA controls? The number of X-ray photon produced, the quantity, that means the intensity of the X-ray beam, and radiation dose to the patient. So higher MAS means what? More electrons striking the anode, more X-rays produced, higher image brightness or density you can see, and a higher patient dose. So this is about tube potential, KV and MA. So also factors involved exposure time, which is measured in seconds, and technologists can select these factors manually. You can place manual MA and manual KV you can put, or they can be selected by using an automatic exposure control. So AEC uses a technique that is called automatic tube current modulation in CT, that will be further explained later. Constant milliamperage. So selection of MA and time separately, or MAS, before the scan begins. So all other technical factors are constant, and MA, the quantity of photon incident on the patient for the duration of the exposure. The dose is directly proportional to MAS. If the MAS is double, the dose will be doubled. So as we already explained, the KVP determines the penetrating power of the photon from the X-ray tube. Higher KVP, higher energy photons can penetrate thicker object compared to lower KVP X-ray beams. Generally 120 KVP is used for adult scanning, and in pediatric you can reduce it to 80 KVP or 100 KVP, you can reduce it. And radiation dose is proportional to the square of the KVP. Collimation have a significant role in dose reduction, so which defines the beam width for the examination, how much beam is required. So reflects the efficient use of X-ray beam at the detector. So in a single slice CT scanner, the entire beam width and penumbra falls on that particular single detector. Penumbra does not, as we know, the penumbra does not produce the image, but it affects the patient dose. Now we'll look into what will happen if the beam fall on multi-slice CT scanners. So in multi-detector computer tomography, the beam width including the penumbra would fall on the finite set of detector. There are more detectors which are inactive, that is according to the beam is according to the FOV that we select. So the beam width is increased, so the penumbra extend beyond the active detector. So here use of wide fan beam or cone beam covering many detector rows, and beam width covers the entire detector array. So when we discuss about the penumbra effects, penumbra exists only at the outer edge of the full detector array. So central detector receive full beam intensity, and much less radiation falls outside the active detector. So most of the radiation falls within the active detector, and much less radiation falls outside the active detectors. Pitch is another important dose reduction factor, that is nothing but the table increment per 360 rotation divided by beam collimation. So which is inversely proportional to patient dose. By increasing the pitch from 1 to 1.5, which produces a 33% dose reduction. So if you are increasing the pitch, the dose will be reduced. If you are increasing from 1 to 1.5, around 33% dose reduction you can achieve. Also, larger pitches produces lower radiation doses and achieve faster scan times, but produces more image noises. We are not looking into a high quality image, we need a optimum quality image with optimum dose. So it is absolutely fine which is producing more, at least little more image noise. That is absolutely fine if you are getting an optimum quality image. And also decreased spatial resolution and helical artifact. So you have a lot of benefits and with few demerits. And also in pediatric protocol specifically, we have to focus should set with pitches approximately between 0.9 to 1.5, with the exemption of maybe temporal bone. So where you require higher details, those except that you can use 0.9 to 1.5 pitch for pediatric. The number of detectors also have a significant role in radiation dose. So the measured radiation dose is inversely proportional to the number of detector rows. So as the number of detector rows increases, the dose decreases. So more radiation dose reduction strategies are there, techniques are there. So that will be explained in the next session. Thank you. Thank you once again to one and all.